Good morning, good afternoon, good evening, wherever you might be joining us from. You're all very welcome to phase 2 of the 6th Global Symposium on Health Systems Research. The symposium has gone virtual this year, as you all know, and we are into the second phase of this exciting journey. Today, we have a session on health systems resilience and adaptation to climate change lessons from developing countries. We have a very interesting panel lined up today, and we're going to look at climate change from the community level, then move up to the health system, talk about stakeholders involved, and also how we can use evidence through research and also improve policy making. So I will go straight away and introduce the first speaker today, and that is Professor Magdalena Rathi, who will talk about climate change, health, and resilience at the community level for social justice. Magdalene and her colleague Laura Rathi are the co-founders of Planitude Foundation, a think tank based in the Dominican Republic devoted to sustainable development. Magdalena is a health systems research and finance expert, and Laura is a biologist specializing in climate change and coordinating the Complex Systems Lab. Dr. Carlo Franco, an expert on climate change economics from Virginia Tech, is also an author for this presentation. You're very welcome, Magdalena.
Hello, greetings to everyone. I'm going to present on planetary health and resilience at the community level for social justice. First, some context of our research. It is in the Hispaniola, that is one of the most vulnerable islands to the impacts of climate change in the world. It is located in the Caribbean Sea. Our study focuses on the Dominican Republic, which occupies 2/3 of the island, which it shares with Haiti. Health impacts due to climate change include epidemic outbreaks of infectious diseases and waterborne diseases. The country also experiences frequent drought periods and low availability of water. The purpose of our study is to assess the socio-ecological vulnerability of 2 municipal districts of the Dominican Republic, to construct a planetary health and resilience index and diagrams based on exposure, sensitivity, and adaptive capacity, to identify key leverage points to build resilient health systems at the community level. The methods include building the Planetary Health and Resilience Index, for which we gathered economic, socioeconomic, biophysical, and health indicators, as well as infrastructure and health resources data available at the community level. We applied complex system tools to prepare vulnerability diagrams. The focus were 2 vulnerable and poor municipal districts, Santo Domingo and Las Terrenas, with high pressure on natural systems, poor land planning, and serious socio-environmental problems. These are some of the indicators we had to gather. I'm not going to read that. And then the results. First, Santo Domingo National District, which has very contrasting realities. It is the main urban, industrial, and commercial center of the country, has the highest urban density coastal area and highest vulnerability to climatic shocks. It is divided into 3 zones that have great differences in terms of exposure, sensitivity, and adaptive capacity. There are also environmental challenges that impact people's health. For our research, we choose the zone 3, which is the most populated, has the lowest multidimensional quality of life index, poor quality of housing and environmental degradation. There are informal human settlements by the Osama River, prone to flooding. The river is polluted by industrial and urban waste that negatively affect health. The other municipality is Las Terrenas, which is a coastal community at the northeast of the country in the Samana Peninsula. It is very important for tourism and has also other economic sectors like fishing and agriculture. 60% of the population is concentrated in the coastal urban area. There are several waterways that tend to flood with each storm. It is highly vulnerable, has heavy rains, coastal erosion, sea level rise, storm surges that impact homes and other coastal infrastructures and ecosystems. The urban area is sensitive to the impact of floods, given its low coastal location and the proximity to Las Terrenas River that runs through its center. There are also non-climatic stressors such as environmental degradation and pollution by solid waste and sewage that impact the river, dragging them to the sea. We prepared a chain of impacts applying a complex causality tool. National District and Las Terrenas Municipality present the same challenges in the face of climate change and variability. Both present environmental degradation that is the cause and at the same time the effect of vulnerabilities and pressures on ecosystems and the health and well-being of the population. This is an example of the chain of impacts and the complex dynamic interactions among several factors. Then our conclusions. The key leverage points of the system, we try to identify them. The most important nodes that link the entire chain of impacts are water and the urban environment. The components of the socio-ecological system reinforce the links between environmental and social problems. Poverty, environmental degradation, and vulnerability to hydrometeorological disasters are interlinked and provide feedback to each other, aggravating household vulnerability. Interventions in the key leverage points to reverse the vicious cycle. There is a high interdependence on health and natural resources within the community level. The destruction of habitat and climate change are drivers for the decrease in the environment that facilitates the emergence and spread of new diseases such as COVID-19. The most interactive components are water and the urban environment because they have direct and indirect interactions on resilience, health, human capital, social protection, and governance mechanisms. The importance of the natural environment in supporting human health and well-being is evident when the environment is degraded and cannot provide ecosystem services. The restoration of coastal ecosystems help regulate hydrodynamics and microclimate, thus providing protection against extreme hydrometeorological events and dangers related to the coastal dynamics of the sea. So, increasing resilience to the impacts of climate shocks on human well-being and to build a resilient health system requires a better understanding of the relationship between the natural and the health system. The knowledge of these connections can lead to improvement in policy development that tend towards resilience and sustainability from a preventive perspective. The recognition of the benefits to human health derived from the sustainable use and conservation of natural systems. Thank you so much.
Thank you very much, Professor Magdalena, for sharing that experience from the community level, and especially highlighting the link between nature, the environment, and how that is very important in supporting human health and well-being. We now move to the health system level, and we will hear from Farida, who's going to talk about building health systems resilience through a localization approach to epidemic control, lessons learned from acute diarrheal disease outbreak in Somaliland. Farida is an early career public health practitioner who recently completed her Master of Public Health. While working with the Canadian Red Cross and the United Nations High Commissioner for Refugees, Farida has become increasingly interested in understanding how humanitarian organizations can work at the community level to offset the burdens placed upon fragile health systems facing rising climate change and global displacement events. You're very welcome, Farida. Over to you.
Okay. Hi, everyone. My name is Farida Al-Awi. I'll be presenting on my research on how localizing epidemic preparedness and response programming can add to the resilience of health systems. I'm going to be using the promising example of the Somali Red Crescent Society programming done with the Canadian Red Cross. And I would like to thank the Canadian Red Cross's Global Health Unit and all of their guidance and assistance in allowing me to do this research. So in the event of disasters, including naturally occurring and human-made disasters, all 6 building blocks of the health systems are affected in one way or another. When considering fragile and strained health systems, the event of a single disaster can have detrimental and long-lasting effects on the most vulnerable populations, including displaced, marginalized, and remote populations. Therefore, improving health systems resilience is needed to ensure that in event of increased health needs, that the demand is met while also ensuring that service continuity is also sustained. And as climate change events have increased in recent years, the health demands have also increased drastically, especially in many low and middle income countries. Meeting the compounding demands is often not feasible, and there's an increased reliance on international and local humanitarian assistance to fill the necessary gaps. Traditionally, this is a reactive process that is unsustainable through the deployment of mobile hospitals or staff that leave once the imminent health needs are resolved. And while this is often a necessary primary step, we argue that shifting towards a localized approach to international humanitarian assistance that is as local as necessary, as local as possible, and as international as necessary, builds the health system resilience and communities to achieve better outcomes for all affected. So some properties of health system resilience include awareness of the health needs of the population being served, adaptability to changing needs, diversity of services provided, and integration with stakeholders and communities. So local actors are always the first responders, not only because of their closeness to what has happened to the emergency, but also because of their intimate knowledge of the weaknesses, strengths, and resources available in their community. So localizing epidemic preparedness and response programming operationalizes their role by ensuring they're equipped with the necessary knowledge, funding, and support needed to implement programs in the best way possible. And some of these properties are highlighted on the right here in the localization framework here done by the START network. The Red Cross Red Crescent movement is in a good position to implement this organizational shift towards localization due to its 192 national societies and 11.6 volunteers globally. So looking at the example in Somaliland, which is a conflict-affected setting that is also low resource, it has many vulnerabilities, including a high internally displaced population and yearly droughts and floods that have had detrimental effects on the agriculture, thus also detrimental effects on food and water security. The country has also had a lot of diarrheal disease outbreaks in recent years, notably a cholera outbreak in 2017. And this outbreak in 2017 triggered the deployment of a cholera treatment center by the Canadian Red Cross to support the Somali Red Crescent Society. Following this, it was apparent that in order to better anticipate diarrheal disease outbreaks and other common ailments, that an epidemic preparedness and response program was needed. The Somali Red Crescent Society collaborated with the Canadian Red Cross and the Norwegian Red Cross to design a localized approach with the focus of ensuring local actors had the ability to detect diseases early as well as respond early in order to reduce the burden on health systems and reduce morbidity and mortality. I'm not going to go too much into detail about the program components. However, the main parts are community-based surveillance of select diseases, training of volunteers in first aid and prevention methods, and finally making resources available for the cholera treatment center, stocks of wash products, technical guidance available from partners, and availability of flexible funding to support scale up. The program proved hugely successful in 2019 when the community-based surveillance network detected someone with or a hotspot of diarrheal disease symptoms. Due to this early detection, it prompted the reporting to the Ministry of Health Development, the deployment of a cholera treatment unit, and the scale-up of community outreach activities. Over 2,000 cases were treated, 22,000 persons were reached through community outreach, and the outbreak was contained in 2 months. This shows promise that focusing on the strengths of community members can hugely add to the resilience of the health systems. In this case, having local actors improve the diversity and integration of the health system by allowing local actors to fill gaps in the health information and health service delivery. Localization also improved the adaptability of the health system through the ability to scale up resources of the response. And finally, 67% of the persons affected were in this 2019 acute diarrheal disease outbreak were internally displaced populations, and 70% were under the age of 5. So reaching these vulnerable populations added to the equitability and trustworthiness of the health system. So some lessons to be learned from this is that we need to advocate for organizational shift rather than just a programmatic shift in making sure emphasis is given to localization policies. Second, we need to ensure that budget allocation specifies capacity building requirements to ensure its implementation. As seen in our example, involving local actors in all aspects of programming is extremely valuable, and in developing equal partnerships and greater potential for program ownership. And lastly, we argue is involving health authorities in localization activities and advocating for their adoption at the community level of community level capacity building to bring national policies and therefore greater geographic reach. So from just one example, we can see that localization has great potential in improving the resilience of health systems. As we've all been grappling with the COVID-19 pandemic, it's important to note that the Somali Red Crescent Society was able to detect the first presumptive case of COVID-19 through the community-based surveillance network. And applying this epidemic preparedness and response program to other settings may prove further useful in not only reducing disease spread and mortality, but also in further building the resilience of health systems worldwide. So thank you so much for listening to my presentation, and I look forward to any questions you may have.
Thank you very much, Farida, for continuing with the community, but linking it to the formal health system and also focusing on a specific disease. Thank you very much. We'll next listen to Jem and Camille, who will talk about a stakeholder-based assessment of barriers to climate change adaptation of local health systems in 2 at-risk provinces in the Philippines. Jem Sigua and Camille Samson are analysts from the Philippine Country Office of Think Well, an international organization that conducts research on health systems development. The team is led by Dr. Gelo Apostol, a private sector specialist of the Think Well and the lead environmental health specialist and assistant professor from the Ateneo School of Medicine and Public Health. This research that they're going to present was supported by the Provincial Health Officer of the Province of Antique, Dr. Leoniosi Abriera. Very welcome, Jem and Camila.
Good day, I am Dr. Jello Apostol of Think Well Philippines and lead investigator of the study, a stakeholder-based approach to assessment of barriers to climate change adaptation of local health systems in an at-risk province in the Philippines. Our study begins with the recognition that climate change adaptation in health, or CCAH, is a multi-sectoral issue that goes beyond the environment and health sectors. How climate change affects health is in fact influenced by various socioeconomic and environmental determinants that dictate the variable exposure and vulnerability of populations and health systems to the impacts of climate change. As such, CCAH initiatives, to be effective, should engage stakeholders from these other sectors. And to this end, stakeholder analysis and mapping provides a valuable approach in understanding how these different stakeholders respond to and may be mobilized to strengthen CCAH initiatives on the ground. To present how this approach was carried out in an at-risk province in the Philippines, my colleague Camille Samson.
The Philippines ranked second among countries most impacted by climate change in 2018. In particular, the province of Antique from the Western Visayas region classifies as one of its high-risk provinces. In fact, 15 out of its 18 towns are coastal towns and are at high risk of being impacted by cyclones and storm surges. While the rest of the island and its farming and fishing economy are also affected by gradual changes in temperature, ocean acidification, and sea level rise. Specific to the impacts of climate change on health, the region has been reporting increased hospitalizations due to extreme heat and increased outbreaks of vector-borne diseases, such as dengue over the past decade. In the years to come, these early impacts of climate change to health are projected to rise and expand, affecting multiple population groups and sectors. In response to these circumstances, the study aims to map the various stakeholders involved and affected by the impact of climate change in health. It also aims to understand the dynamics and relationships between these stakeholders and from their standpoint, identify the barriers and facilitators to implementing CCAH strategies in their context. To carry out these objectives, stakeholders were identified and mapped with local process owners. Clustered snowballing was then used to engage these stakeholders to identify their roles, level of knowledge, position, and resources for CCAH. Cognitive interviewing was used as a technique for this, and also to elicit barriers and facilitators in the implementation of CCAH strategies. The interviews were also validated and cross-referenced by a parallel review of relevant documents in the past 10 years. To present the results of the study, Dr. Apostol.
Thank you, Cams. Our stakeholder mapping was able to identify 42 stakeholders, well distributed and color-coded, as you can see, depending on the sectors where they operate in. Blue in the health, yellow in the environment, green for both, and orange for other sectors. Each stakeholder is then further characterized by the amount of resources that they have, indicated by the size of the circle, and afterwards placed on the matrix corresponding to their level of knowledge and intensity of support or opposition towards CCAH. When analyzing this matrix further, one can glean that the CCAH agenda in our study province is actually driven by stakeholders from the environment and climate change sectors. And this is largely due to their higher level of knowledge, resources, and socio-political capital compared to the other sectors. In general, the health and other sectors remain ambivalent towards CCAH, and this is highly associated with their limited issue and sense of urgency towards CCAH. It is also worth noting that vulnerable population groups such as women Children and indigenous people are likewise equipped with limited knowledge, capacity, and sense of urgency towards CCAH. In addition to mapping the stakeholders, the relationships between the different actors were also explored through qualitative social network mapping, focusing on the flow of money and information between stakeholders. And if you notice, much of the interactions in the flow of money, information, and accountability occur within the sectors and very minimal between different sectors. This turfing or hands-off stance is discussed later in the barriers. That being said, some stakeholders have also been found to convene all other stakeholders, particularly the DRRM and Health Unit and their DOH regional offices, as well as the local executives such as the governor, mayor, and representative. Moving forward, these multiple leverage points can be optimized in pushing for CCAH as a multi-sectoral agenda. As mentioned, we did a force field analysis of the interviews to assess the drivers and barriers to CCAH implementation, and to explore these, my colleague, Ms. Jem Arsigua.
So the next few slides will explore the specific barriers and facilitators for each of the 6 themes that we identified. On the left side, you can see the facilitators, while barriers are presented on the right. So first, we have strengthening multisectoral coordination. We found that there are champions or advocates within the local government of Antique who can link different sectors, including non-government organizations. However, there is still conflict and a lack of awareness among the different sectors and political levels. Second, on the development of policies, we found that there already are existing laws that are aligned with international policies and guidelines. However, these are outdated and are too broad, and there is also a lack of monitoring in its actual implementation. Third, on resource and financial support, opportunities for funding are present through international and local channels. However, there are no currently existing structures that can guide the financing of CCAH initiatives in the province. Fourth, on capacity building of health providers, trainings are available and policies are in place. However, these trainings remain to be only at the basic level. Retrofitting or climate proofing of hospital facilities do not seem to be a priority as of the moment as well. Thus, the health system response remains to be more reactive than proactive. Fifth, on monitoring and evaluation, we found that the data, capacity, and technology are available. However, there is poor prioritization in terms of conducting local researches as well as monitoring and evaluation. There are also inconsistencies in gathering and reporting of data, especially in geographically isolated and disadvantaged areas where connectivity is more limited. And lastly, on improving community awareness and resilience against structures that can facilitate this are already in place. However, these are at basic levels and do not reach those who are actually vulnerable. More importantly, the socioeconomic determinants of vulnerability to the health impacts of climate change remain largely unaddressed.
Thank you very much, Jem. And bringing to bear these findings from the stakeholder mapping, network analysis, and force field analysis, we make the following recommendations. First, we recognize that stakeholder awareness is a key driver of position and commitment of resources to CCAH. And as such, interprofessional education across sectors can be pursued at all levels. To further galvanize these multi-sectoral participation in CCAH, it's recommended that specific linkages and entry points between CCAH and other sectors be identified and be used to anchor collaborations and strategies. Further to this, co-benefit between CCAH sectors and other sectoral agenda must be pursued, and the returns of investment to CCAH must be well communicated to stakeholders. Of course, underlying an effective CCAH strategy would be adequate investments in data and decision support systems to adequately inform policies and strategies. And ultimately, all sectors within and beyond the health system are enjoined to work together in addressing the larger socioeconomic determinants that influence climate risk, and only then can we truly push for climate resilient health systems and communities. Maraming salamat po.
Thank you very much, Dr. Apostolo and Camille, for that presentation. I mean, it's very evident that we have a multi-sectoral approach to CCAH, at least in that province in the Philippines, but that's not enough. To have several actors, we also need these different actors to talk to each other and work together in a meaningful way. But also something that you highlighted was reaching the vulnerable and those who are affected by climate change. And next, I would like to introduce Shibai Bose, who's going to talk about how can research engage with policymakers for improving health system adaptation response for populations vulnerable to climate change, learning from the Knowledge Intervention Project. Shibai Bose is a health systems policy researcher whose work draws on a long-term visual ethnography in remote and challenging geographies. A former journalist, currently he is working on the linkages between climate change, health systems knowledge interventions, and policymakers. Alongside his interests in mediating between dominant and implicit narrative spaces, he has co-curated photo voice exhibitions, directed films, and his works have featured in Wellcome Trust and Cannes Film Festival and the Health Systems Global Symposium. Very welcome, Boss.
Congratulations and thank you to Health Systems Global and our staff who made this possible to have the symposium. And so I am Shivaji Bose, and I and my colleague Upasana Ghosh has been working with other colleagues from Future Health Systems since the last decade on the health systems and policy, and which has resulted and informed this presentation. So Indian Sundarbans is a global climate hotspot. The frequent climate shocks like flooding and cyclones is not only impacting the biological determinants of health, but also the social determinants like livelihood, shelter, and social relations by altering or transforming the same within a given context. It's an island of 5 million population, 104 islands of which 54 are habitated. It has got both a high burden of communicable as well as non-communicable diseases. So if you see, when we started, so the first thing that we wanted to find out was to understand the background, what works and what does not in socially embedded authority relations and cultural context. Does the situation consider the plural frames of knowledge? Does the policy making consider the plural frames of knowledge? Does the dominant policy narrative ignore the underdetermined realities of health systems? So in this case, we found out in the knowledge pathway, since the plural frames of knowledge were not involved, that led to some sort of an uncertainty in policy action. So if you see both the quadrants here, one is the health indicators of the population, and on the right side is the policy. And when we first started, it was a very top-down kind of research in which surveys were done, and surveys where tools were top-down. It didn't involve communities, and the findings fed the policy making to the health system supply side. And then there was this healthcare delivery, which was one size fits all. So we observed and listed what is the current evidence in a way to policy environment. How is the evidence highlight in a region where climate shock and the realities of population are being ignored? And this resulted, we saw, into a knowledge gap. So our conceptual understanding was, if you see on the left, we stressed on building capacity. We began with this understanding that we have to build capacity of both the demand and the supply side. We have to get the community involved in creating knowledge in order to improve health. For this, the research, we had a multi-method and vertical longitudinal approach. We had participatory, qualitative, and quantitative data collection. You've got participatory methods to generate community voice and short periodic surveys to see how the discourses and narratives are changing. So if you see in the knowledge intervention, we simultaneously, what we did differently, but we simultaneously fed all the three boxes here. And from the beginning, we got a buy-in from the policy on the research, on the knowledge intervention, and also arranged visit of the decision makers to the remotest portions of the archipelago. The intervention process was, we considered the local and mainline media, and also the mainstream media. We had continuous engagement. We used full use of the online and digital platforms. We used the vernacular media, and the Sundarban's Health Watch, we used it as an alliance building initiative other than dissemination initiative of government agencies, local clubs, informal health sectors, and civil society. We use to train so that they can use research to write evidence-based proposal on health. So in the findings, we found out what worked and what did not. And what worked in community involvement, the multi-stakeholder meeting worked well. The community voice, the photo voice worked well, which is the community, participatory action research technique. The capacity building worked well, and last but not the least, the local media. It had a wonderful effectiveness. So in the end, what we did was we could manage to bring in the collaborative knowledge frame on the left and the right. So the community and the policy makers, but what we did right, we brought them into by creating spaces for scientific, technical, administrative, and daily existence-based knowledge sharing, which led to the knowledge pathway. Experiences and the learnings. So we used experiences from research evidence. We used, after the health watch, so we got this West Bengal government to pilot a study on malnutrition. Access, we had the Mothers Hub in one of the island blocks, and it was a model intervention. And we mainstreamed the informal providers who are 24/7 providers. This was the experience, learning, the impact of the study. And we look forward to receive your comments and your questions. Thank you.
Thank you very much, Shibai, for those great insights into research and how we can use research to move to the policy level and also improve adaptation at the health system level. So that was the last presentation that we have in this session, and I encourage you to use the live Q&A to type in your questions. So I will go straight to the questions, and thank you very much to all the panelists. And perhaps before I move forward, I would like to say that if you can look at the live, the on-air events page, you can see that I am the chair for this session together with Renzo, who I will introduce later on. So be patient, you will all hear from him as well. So the first question comes from Amanda Quintana. And this is the question. Disaster response is not synonymous to long-time climate change impact. And Amanda is wondering if any of the panelists have looked into long-term climate impacts on health systems and have any comments on how this can be further studied. So, any comments from the panelists? I will not call out any of you, but I hope it can work that whoever wants to speak can make a contribution.
Hi, Dorcas. So I'm not sure how much I can say about the research part of it, but looking at climate change impact and disaster response, I know that disaster response is a lot more reactive, and that's why we want to make it more predictable, having a way to kind of see who's going to be affected and like forecast what might happen in order to plan accordingly. So the IFRC actually, or the International Federation of the Red Crescent, does a forecast, is pushing for more of a forecasting approach and forecast-based budgeting in order to make sure that hopefully we are able to deploy or build capacities before emergencies happen. And that's kind of like what I can see from when I'm looking at disaster response versus climate change impacts, versus, sorry, long-term climate change impacts. I hope that answers the question a bit.
Thank you very much, Farida. Does anyone else like to comment?
Yeah, I haven't walked in Sundarbans, which is considered to be one of the climatic hotspots. It's I would say it's a tough ask because all these verticals of the health system is one. Health department does one thing. We have a different department called disasters, redressal disaster, and then the third department, which is the general administration. And we also have a climate change department. One way it can facilitate the discourse between the disaster and relief and also the climate change studies that comes out, that's one way, is to facilitate an ongoing discussion. But at the same time, you can build for a disaster, but in the case of the Sundarbans, I would say that when a big disaster happens, and it's not only the immediate effect of the disasters, but it is a trickle-down effect which leads to a huge amount of of migration, and that also has its health effects. So it's a very complex problem, and it needs to be, more research needs to go into it.
Thank you very much, Shibaji. Any comment from Professor Magdalena? Okay.
No, I would like to invite Laura or Carol, who are the experts on climate change. Maybe they are participants, and maybe they would like to make some comment.
Okay, as we wait for them to perhaps get on and make some comments. Camille and Postel, do you have any comments to this question?
Sorry, Dorcas, they are trying to speak, but they don't know how to do it. Could you explain? Because they are participating.
Can they use the Q&A live chat to make comments? I'm not sure if they cannot come through with the microphones, then they can use the live Q&A, and I will read out their comments. Perhaps then I will move on to a question for Camille and Apostol. You talked about the presence of CAH policies or policies related to this, but a very poor implementation of these policies as one of the main issues. And this is perhaps not unique to CCAH. In several sectors, including health, we know that policies are very well written, but the implementation is always not as good as the policy itself. In your experience, what would be your advice on how to better implement these policies, because policies are as good as their implementation?
Hi, Dorcas. This is Jem. I'm representing our team. So yeah, we mentioned that we do have policies already, not just for climate change and health, but for health in general. And I want to point out that Philippines is has a decentralized health system, which means that our local government units implement the policies on their own, while the national government just provides support and direction on how to do it. In our case, in the Philippines, in a decentralized health system, I think it's really more about building the capacity of local government units to be able to more effectively implement these policies. And I think more than that, they should also be trained or taught about the technicalities of these policies on especially on like how climate change affects health and everything, so that they can appreciate how the programs and policies would be able to help the health system in their localities in general. I think effective capacity building is important.
Thank you. Apostle, would you like to add? Okay, I will then move on to the next question. And this question comes from Christophe de Costa. To what extent do you think global health pays enough attention to this agenda, that is the health system's resilience and adaptation, especially global health organizations like WHO, Global Fund, Gavi, and what should they do to push this higher on their own agendas? So this was not directed to any panelist, so feel free to chip in. Okay, I'm going to park that question. Christophe, I am coming back to that question.
Can I say something?
Yes, Professor Magdalena.
Yes, I think that it is very important, this question, because these global organizations are not putting this, giving the priority that this agenda deserves. And the epidemic of COVID-19 has shown that everywhere that the health systems are not prepared. For example, I think in October 2019, the Global Health Security Index was published. And in that index, the United States and the UK were the countries that were best prepared to respond to the epidemic. And they were some of the countries that performed worst. So the epidemic was terrible in those countries, and they had the highest preparation. And if you look at the results of that index in Latin America, the country which had the highest performance was Brazil, and it was the worst. So in their response, so there is a problem with what we thought was the preparedness for epidemics and what really happened when the epidemic occurred. And this could be with any other of the impacts of climate change. So I think this COVID-19 is opening our eyes that we need to prepare better.
Thank you very much, Professor Magdalena. Okay, that's quite a timely intervention from you, actually, because we have another question from Mohammed Mudanoran, who says, and I will read it out, COVID-19 struck everybody everywhere in the world, in health, the economy, family, mental health, even as an environmental issue, both positively and negatively. What can we learn and do for future preparation and getting ready for the next one? In quotes, hopefully that does not happen. And how can we make this pandemic preparedness a global issue as well as a local issue using the health systems research approach? Does anyone have any suggestions on how we can prepare better? The index for preparation, like Professor Magdalene pointed out, were not as accurate as they had been predicted. So we all know that polls are not usually accurate from very recent elections. But how can we prepare?
Can I say something? Yeah, so I do agree that the COVID-19 has definitely affected our health system very negatively. And at the same time, here in the Philippines, we recently also were just affected with multiple typhoons that were massive in scale compared to what we experienced before. And dealing with something like that in the middle of a COVID-19 pandemic is definitely a challenge for all of us. And based also on our research that we presented earlier, we noticed that there aren't a lot of intersectoral connections that would enable a better coordination for events like these. And the environmental sector and the health sector have their own agendas, and the private sector as well, it's not well coordinated. And we also learned through the COVID-19 pandemic that these sectors really have to work together in order to address a massive health issue such as a pandemic or a climate change or a disaster response. So yeah, I think that in preparing for future pandemic, although hopefully there isn't one soon, or for any disaster response, I think we have to strengthen our intersectoral relationships and coordination.
Thank you, Gemma. Any other response to that question?
Sure. So in I think there is a importance in focusing on planetary health as well as like community health. So all the way from like the big picture to certain communities. So looking at the interaction between humans, their environment, animals, things like that are very necessary in understanding what potential pandemics may be happening and stopping them at the community level, but also making sure, as with my presentation, that communities do have the capacities to identify if there is some spillover that maybe causes unusual health events in their communities, and being able to detect them quickly, but also respond to them quickly in order to reduce the burden of disease on their communities, but also on the world. So in such a globalized world, it is important to kind of focus both on the community level, on all the interactions we have at the planetary level. Yeah.
Thank you, Farida. Okay, I don't hear any other contributions. The next question goes to Shibaji. From your background as a journalist, what sort of practical advice would you give researchers on how to communicate their findings so that they can be translated into action, not only into policies, but maybe perhaps into policies first and then action? So what practical advice would you give, since you have the privilege of sitting on sort of both sides of the fence in relation to the knowledge and probably action gap, if I call it that?
Yes. From the southern context, one has to look at the entire, the journalist ecosystem. So what happens is a journalist covering health doesn't have a formal training, not always. So it is important for anybody who wants to communicate research to do two things, I feel. One is to build the capacity of the journalist to their research agenda, and also about health systems in general. That is one, and this is something that I can say out of my knowledge of being a journalist, not understanding the jargons, and because there is also a rush to do a copy. And from the point of view of when being a researcher, it was important that when you communicate in a manner that they understand. So it's a mix of building the capacity of the journalists, and also making it, thinking from the point of view of a journalist of how easy or they can be, so that they also have an audience to communicate. So these are the two things that I can say, not as a prescription, but as a learning from my own end. Yes, that's. And
Okay.
on the, I just want to add one more thing is on the policy making. We are from the side that we want our research to be disseminated, but at the same time, some of the research are very long term, and there is not an immediacy, that journalists want to report. So in terms of doing that, one has to understand who's the journalist, or newspaper's audience is, and also to align our research findings to their audience. So if it's a vernacular, it is different, or if it's a very dedicated media, then there will be a different audience, and so the approach has to be different. So it cannot be, if you're communicating to 10 different papers, it cannot be one press conference. It helps, but at the same time, one has to be on the individual level with the health beat reporters to know what their audience is and what actually do they want, and then fit the research to them. Yeah, thank you.
Thank you very much, Shibai. I will ask one more question, and then I will let in Dr. Renzo, and then we can continue the discussion. So The topic for this session is health systems resilience and adaptation to climate change, lessons from developing countries. So this is the question, and it's related to that. And it comes in from Christoph de Costa. Does the concept of health systems resilience, because that is the topic of our discussion today, actually help developing countries? Or do you think that we should rather use health systems strengthening and adaptation to climate change? So do you think that that would be a better phrasing as opposed to resilience that could easily be looked at as a rhetoric from global actors? And would this framing make any transformative change in relation to adaptation to climate change and reimagining health systems? So do you think the nomenclature of using health system strengthening and health systems resilience is important in the question on climate change adaptation in developing countries? Any of the panel members can respond to this.
So that's an interesting question. I think when I'm looking at them, sometimes you think as maybe health system strengthening as kind of something that's ongoing versus resilience as something that is like a final goal. However, if you think as resilience of achieving resilience as like an iterative approach that's ongoing, then it becomes like just a word. So I think the main idea is to think of achieving like community resilience and health system resilience through ongoing work. And because the environment that we're in changes, we have to keep adapting to that. So yeah, it's more of, the finality of it, I guess, is kind of what maybe resilience brings versus strengthening, but that's just my thought.
Yes,
very interesting insights. Thank you, Farida.
I would also say the same. I think that I prefer the word resilience, because when you speak of health system strengthening, maybe most people are thinking on services, providing services. And in the case of climate change, resilience to climate change, there are many other factors involved, not only not only the health services, but also all these community services, collective services, and the capacity to respond to emergencies, and the preparedness for emergencies. And sometimes these are, many times at least in developing countries, these are neglected areas of the health system that are underfinanced. So I think that it is important to put this in the front and understand that these are areas. For example, in the Dominican Republic, the financing for all this preparedness to respond to epidemics is less than 1% of the current health expenditure, and that is probably very low. So it is necessary to understand this, and to how can I say, to put it to transparent the financing fund, the financing of this part of the health system. It is very important.
Thank you very much, Professor
Hello,
Magdalena.
can you hear me?
Yes, Carol.
Hi. Yes, this is Carol. Thank you. I just wanted to add to the conversation to what it was said already by Magdalena. And I think resilience is much more of an encompassing term. And it focuses on how we can cope, but by trying to figure out and how we can cope to these shocks or to these changes or impacts, we need to assess how we're doing and what else can come that will affect us or impact us. So it's a very encompassing, also involves research and involves a status that it's flexible enough that you can support, or you can have those shocks and you can come back in a different way maybe, but you still come back as strong.
Thank you very much, Carol.
Can I just add something to here?
Yes, please.
Yeah, for me, this resilience, this word is a bit problematic. I personally find it a bit problematic, because health system encompasses all other, it's all other systems. It's about community, their well-being, their livelihood, and therefore their health, social, mental. So a lot of the time, the discourse is they are resilient communities. By doing so, my feeling is that we are we are trying to, this is kind of romantic notions of, they are resilient communities, they are more resilient to climate shocks. So sometimes what happens is by taking this narrative of resilience, one doesn't actually see the vulnerability. I would look at, like, if there is a vulnerability, if you look at in terms of vulnerability, then if you have a scale, so then it is more easier to be more action oriented in terms of, say, if community is in, say, 3 or 4 in a scale of 10, then what do you do about it to raise it to an optimum level? But the moment you say resilient, then I find it a bit problematic, the word.
Okay, thank you very much.
Can I add something, please?
Yes, Carol.
I agree. The thing is, for me, that I work in climate change, resilience is the other side of the coin of vulnerability. So in order for you to decrease your vulnerability, you need to increase your resilience. So when we're talking in climate change about resilience, and it can be, I think, it can also be used for health system. When you're looking at resilience and trying to assess resilience, you have to, of course, assess vulnerabilities throughout. So you have to do both, because to increase the resilience, you need to understand the vulnerability so you can reduce them. So that's, for me, it's just the same coin, just different sides. Thank you.
Thank you very much, Carol. And thank you all for your contributions. As promised, now I would like to let in Dr. Renzo Guentol. And we decided to organize this session like this because the climate change is a very broad topic, and as you heard from each other's presentations, it touches a lot of aspects. So we thought that Dr. Renzo could sort of sum up or say a few words as well. Dr. Renzo is the Chief Planetary Doctor of PH Lab, a global think and do tank for advancing the health of both people and the planet. He's also Associate Professor of the Practice of Global Public Health, an inaugural Director of the Planetary and Global Health Program of the St. Luke's Medical Center College of Medicine in the Philippines. Renzo is a member of several high-level groups, including the Lancet Chatham House Commission on Improving Population Health Post-COVID-19, Lancet One Health Commission, and the Forum on Climate Change and Health of the World Innovation Summit for Health. Very welcome, Renzo.
Hi, Dorcas. Thank you very much for having me. It's so hard to say no to your invitation. I think it's important to remind our crowd here that this specific panel is organized by the Emerging Voices for Global Health, of which 2 of us are a part of. And congratulations to the amazing panel These are really not just interesting, but important research at the cutting edge. And it mainly because I think this is the first global symposium on health systems research where climate change is actually quite central in the theme. I remember when we were in Liverpool 2 years ago during the closing ceremony, I actually complained during the open forum that out of the more than 1,000 abstracts that were presented during the conference, only one had climate change in its abstract. And actually that's the presentation of Susanna Mayhew from the London School. And so now we actually have several sessions around on climate change and health systems. 2 weeks ago, during the first week of the symposium, I actually moderated another session on this subject, but that one was more about the latest environmental epidemiology research, talking about what is the state of knowledge when it comes to the climate-related health impacts in order to inform health sector programming or health planning. How do we consider climate considerations into health systems work? This time, what we actually just heard is the application of health policy and systems research methods in trying to unpack these questions around climate resilience or climate resilient health system, climate proofing. There's so many terms that have emerged over the past several years, and I would actually invite our audience to take a look into these emerging concepts that try to merge health systems and climate change, climate smart health systems, low carbon health systems. And I think we are just at the beginning of the story in this entirely new phase in health systems development, where now climate change and environmental factors are already being taken into account and being considered. It's interesting that HPSR has for some time already interrogated different forces, culture, gender, politics, the commercial determinants of health. And unfortunately, the environment, I think, is a blind spot of our community. And so it's really great that now we're looking at, for instance, looking at planetary health and resilience index in the Dominican Republic. I think this is a very important and pioneering concept. And also, what I appreciate from this project is that there's an adoption of systems thinking and complexity theory, which are theories that exist outside of the field of health policy and systems research. Only during the past maybe 10, 15 years when we've started adopting these frameworks in advancing our understanding of health systems. And then now we're interrogating, or we're looking at how health systems interface with other systems, ecological systems, food systems, social systems, etc. I really appreciate as well the study from the Red Cross in the Somaliland, especially the concept of localization. I always say that at the end of the day, it's the local communities that are at the front lines of climate change, whether it's natural disasters or slow onset events like sea level rise. My doctoral dissertation actually was about coastal communities in the Philippines, how they are trying to incorporate climate change into local health systems planning, which somehow speaks as well to the work of the Philippine team, which is amazing, and no bias involved. And localization is important. And so hopefully in the next couple of years, we'll see more projects that really look at how local health systems, because HPSR has, and this is my observation, has focused very much on national health systems and national policy. And I think now we need to start to go local and look at how local health systems and communities are responding to, these climate-related effects. Going to the Philippines, I think it's a brilliant example of how health policy and systems research methods and frameworks can be actually utilized to unpack this, complexities around climate change and health, the stakeholder analysis, force field analysis, familiar tools that, we've been utilized in so many different health policy and research health systems and policy research questions, but not so much in climate and health. So I hope our audience will use the Philippine project as an exemplar for this new wave of studies in the future. And then finally, I appreciate the work of Shibaji and Upasana, who I actually also work with on this subject. And it's really important to look at how to translate the evidence. Climate knowledge, climate information is quite complex to digest, to ruminate. And so it's really vital that we know how to package this information in order for health policymakers and planners and health professionals themselves to be able to really understand them. And I really like the discussion as well about the journalists, the role of the journalists. So this is a very important conversation. Obviously, we're scratching the surface. I wish all your papers have already been published. I'm actually currently doing a review now for the WHO as to which are the frameworks that try to merge climate change and health systems that exist. And so, I'm expecting in the next 10 years, there will be more. This week, we should actually all be in Scotland for the climate negotiations. Obviously, that has been postponed because of COVID. This week is a National Climate Change Week in the Philippines. And so this is a very important and timely conversation. And I hope that the health policy and systems research community will now embrace climate change as part and parcel of our work. So thank you very much, Dorcas, and congratulations again to the panel.
Thank you very much, Renzo. And I am just asking the organizers to give us a couple of more minutes. There was a question that wasn't really responded to, and since you mentioned your work with the WHO, and that was in regards to how much attention is being paid to this agenda by global organizations like WHO, Global Fund, and Gavi. So Renzo, would you like to comment on that, and on what should we do to push this higher on the agenda?
Well, thank you to our friend Christoph for asking that very challenging question. Obviously, right now with COVID-19, with climate change also, and all these other forms of crisis, now we are somehow, pressured to really think differently. And that will mean future types of governance, future financing mechanisms, future ways of doing even health policy and systems research. And so I don't have a very concrete answer to Christoph, but definitely this is an invitation to asking ourselves, what is the kind of future governance and health systems do we want that is respectful of the planet's boundaries, low carbon, mitigating climate change, but also addressing the health needs of the people, whether in times of peace, people accessing universal health care, or in times of crisis like a pandemic or climate change. I just want to remind you as well, Dorcas mentioned I'm part of WISH, the World Innovation Summit for Health. Last week, we just had our conference and we launched a report on climate change and health. And you will see there a diagram that we developed, which shows how climate change can actually reverse the achievements that we have in terms of universal health coverage. And so that should be a clarion call to our community to really not ignore climate change. It's going to affect our work. Thanks.
Thank you very much, Renzo. And with that, we're coming very close to the end of our session. And I would like to once again thank the panel members, Professor Magdalene, Ms. Farida, Gemma, and Shibai and Dr. Jello for joining us today, and of course, Dr. Renzo for being a part of this session. As Renzo said, this session was organized and curated actually by the Emerging Voices for Global Health, which is one of the thematic working groups for health systems global. And we thank everybody who has joined us in this session, and I hope that it has been interesting and informative and a bit helpful, at least, in moving the agenda of climate change and health systems resilience forward. So thank you very much. Enjoy phase 2 of the symposium and hopefully see you in another session. And thank you very much for the technical team behind the session. Have a good morning, good afternoon, and good evening. Bye.
Thank you. Thank you, everyone.